For the discussion, we'll go ahead and go to our next, oh, perfect, there we go. There we are. With our next three presenters, we're very excited to talk about the evolution of cancer care during the time of COVID-19. So super excited to have Laura Makarov, who is part of our ACS team on the national level for the Prevention and Early Detection branch. So Laura, nice to see you. I know most of the time we all get to see each other when we travel, but thanks so much for being in Colorado, a part of our work today. Linda Oberholzer, who's the Associate Professor in the Division of Internal Medicine and a longtime supporter of the coalition. And Erin Best is going to also share some patient perspectives. So we're really delighted, Erin, to have you. And I think this is an awesome opportunity to hear from national as well as local work here in Colorado, as well as the interface of the patient perspective. So Laura, I think we'll go ahead and start with you, and thanks so much for being on today.
Sure, glad to be with you all. We can go on to the next slide, and I'll do a quick introduction. I'm sure you guys saw my bio or intro somewhere, but just so you know who I am, where I'm coming from. Number one, I'm from Colorado, and that's a picture I dug up from my back deck the last time I lived in Colorado. So there's the Colorado sunset. So I grew up in Colorado Springs and did my residency at University of Colorado, and then spent my early part of my post-residency life and practice in Parker, and then we moved out east to DC, and now I'm here in Atlanta. But anyway, I'm always happy to get to engage with Colorado folks, and miss you all. My folks still live there, so I get to come visit sometimes. I'm a family physician by training, and I've been at ACS about 3.5 years. I lead our prevention early detection team and cancer control here at ACS. So I'm going to talk today about a couple things, mostly around screening and what's going on in cancer screening from a national perspective amidst the pandemic. So here's a couple learning objectives for us today. Number one, I'm hoping that you leave today with an increased understanding of the impact of the pandemic on cancer screening and diagnosis. And then also want to leave you with some considerations about how to help your partners and your patients and your health systems that you work with return to screening safely. So you can move to next. So just a timeline. I think this will level set. I'm guessing you've talked about this already today in your time together, but let's just level set on where we started, and then we'll get to kind of where we are. So remember back in March was when the national US emergency was declared. At that time, appropriately so, lots of organizations, including the CDC, us at ACS, and then lots of specialty organizations made recommendations about stopping or postponing any elective procedures, including cancer screening. So with that, we started to see some really steep declines. So that was the beginning of things. So let's move on to the next slide. And this is some data from the Epic Health Research Network, which is as you probably know, a big research network with Epic users. So this is the best EHR data and most up-to-date data that I've been seeing is coming from this group. So this is EHR data that really looked at just cancer screenings that were completed by EHR data across their member organizations. And we saw steep declines between 86 and 94% for breast, colon, and cervical cancers that are depicted here. This is data from, I think it was April. Let me check my notes. So really kind of early on. Yeah, it was published in May. So it was really data from around April. So we saw this big decline. The lighter lines there are the previous year's rates of cancer screening. So you can see this really steep decline. So then some other data on the next slide from IQVIA, who you may know, they're an organization that uses claims data from a bunch of different sources. And so their early report, said the same thing, basically, that we were seeing unprecedented drops in breast, colorectal, and cervical cancer screenings, decreases of 83 to 90% compared to previous 3-year averages. And you can see the numbers there for the various cancer screening tests. And then importantly, even back then, there was just a growing recognition and concern about the backlog we are expecting of cancer screenings and the challenges that's going to pose for health systems as we deal with how to safely restart screening down the road. So this was early on, again, like May-ish from my memory of when this was published. And then the next slide. So this is a study from Quest Diagnostics that's using ICD-10 data to look at any test that had an ICD-10 diagnosis code related to one of the most common cancer types. And that included breast, colorectal, lung, pancreas, gastric cancer, and esophageal cancer. So what this is showing, this cross-sectional study, really is looking at the weekly count of tests was tracked starting with the first full calendar week of 2019 all the way through April. And then what it shows is that the weekly number of lab tests through Quest that were being ordered fell from 46% for the 6 cancers combined, so minus 46%. So the rate of cancer diagnosis is also going down. So it's not just the screening that has been impacted, but also other testing, other lab tests related to cancer diagnosis or early treatment is also going down based on this data. So I think the next slide speaks to this also. So this is another IQVIA look at the data. And it really showed, the estimate of over 22 million screening tests for the 5 common tumors will be disrupted or being risk delayed for about 80,000 patients. This was their projection. The takeaway here is that could result in over 80,000 positive cancer diagnoses being potentially delayed across the nation. So I think there's 2 issues here, and this is what we've been working on with my team and kind of my daily life nowadays. 2 issues. One is cancer screening, and then the other one is any other cancers that maybe that we're missing, right? That are going undiagnosed that wouldn't be caught by screening anyway, just because people's care has been disrupted for lots of good reasons, and then some other reasons that we would want to be able to overcome. So the next slide, I think you saw this earlier. So this is Dr. Sharpless's paper that was out in Science earlier this summer. That was the modeling from CISNET that says that we're expecting about 10,000 excess deaths from breast and colorectal only over the next 10 years. So those are deaths that could be averted if we could get back to screening safely, get people engaged in care safely, and be able to resource appropriately so that health systems are able to do non-COVID care amidst all of the COVID surges as well. So next slide. So things started to look a little better. So those were kind of early on things. So things started to look a little better as we as a nation got a handle on the pandemic and as health systems started to implement new policies, new safety protocols that I'm sure you all are a part of and aware of. And this is a repeat of that EPIC Health Research Network study that was done in June that really showed some return of screening. So you see that drastic dip as the pandemic started, right? And you see the curve recovering. But still, this look at the data said that there's still about 30% less cancer screenings being done through the summer. So we're still concerned that there are screenings that are not being scheduled for good reasons, some really good reasons, right? There's obviously COVID surges happening all over the place. And we want people to be safe as they return to screening. But we wanted to recognize that there's still, even with this rebound and a lot of health systems recovering and getting back to some pre-pandemic rates of care, that we still expect that there's some delays in cancer screening happening. Okay, next slide. So then just another look at this, I just wanted to kind of mention also, not just, this sort of, let's just say, the population level of cancer screening and people who were, missing their care and screening, but also thinking about the impact on people with cancer. And I know we'll get to that as part of the rest of this panel. But I wanted to just highlight this recent survey that our Cancer Action Network did. So we've been surveying cancer survivors throughout the year. This was the most recent iteration of it that looked at, so let me get the dates right for you. So this is a survey conducted from the end of August to the middle of September, and the data from that. So later on in the pandemic. And what we're seeing is that still nearly 1 in 3 of patients in active treatment are experiencing delays or cancellations in their cancer-related care. And then you see the other numbers there that 54% experienced the delay or cancellation due to some logistical issue like an office closure. 31% experienced a delay or cancellation because the provider or facility was concerned about the patient's risk of coming in. And then 25% personally initiated the delay or cancellation. And then on top of that, and I think this is a nice follow-on to the talk that you all just had that I got to listen to the tail end of, is the emotional impact of all of this. And so what those numbers are showing there on the bottom is that 64% of people with cancer in this survey are concerned about their ability to stay safe as the pandemic continues and as cases increase. And then 45% are concerned about the impact on the healthcare system. The other important part, maybe even more so this week as we're all living through the election and the impact of that, is that half of the respondents here, and I would estimate that even this is a decent sized survey, but I'm guessing that this issue of ensuring comprehensiveness of health insurance is really it's top of mind for so many people, especially as we're seeing job loss and unemployment and insurance going away. So all of that to just set the stage and give you a sort of the national picture of what we're seeing in the data that's available, recognizing that we're all going to be learning so much along the way in the coming months and years, I would say, as we're able to get a handle on the real impact of the pandemic on cancer screening. So let's shift gears. I only have about 25 minutes, so we're going fast here because I want to leave time for the rest of the presentations and some question time. So let's shift gears and now talk about what do we do about resuming cancer screening. So a few challenges to think about on the next slide. So number one, like we just saw in all of the data in the papers, that we were seeing this unprecedented backlog of cancer screening. So this is going to require, and probably already is, requiring health systems to think in new ways and adopt new processes and protocols. The health systems and screening centers have had to, adapt and adopt new cleaning and social distancing protocols, and some of that has led to this lower availability because we're spacing patients more and having less throughput through systems. The varying COVID infection rates across the country and the regional variation, I think we all expect will continue, and that's a real challenge as we look at it. For you guys at the state level, for us at the national level. How to help people navigate as COVID levels, fluctuate. And then as we start to see flu season pick up, I think that'll be the added challenge to all of this as well. And then we're also, hearing about and seeing that there's some real patient fear, reluctance, and confusion about how to engage in care safely and whether or not they need to be thinking about prevention right now or whether it's okay to delay. So that I think adds to things. This other issue of the complexities of shifting to telehealth, I know Dr. Oberholzer is going to speak to that some. So that's another both opportunity and challenge, and so that we need to consider that. This concern about decreased primary care capacity, I think, is out there. What I've been seeing in the national data about primary care visits across the board, both at health centers and other, private settings, is that a lot of places are recovering, but some of the smaller primary care clinics and others are facing really significant financial challenges, and there is a real concern about the long-term impact of whether or not the primary care workforce is going to take a big hit in terms of people being able to stay open for business because of the impact of all of this. And then I mentioned the staggering loss of employment and employer-sponsored health insurance, another challenge to navigate. And then, of course, want to keep front of mind, we just want to recognize that all of this, as well as the sort of, double whammy impact of COVID-19 and cancer disparities on historically marginalized and underserved populations, just needs to be top of mind for all of us as we remember and think about how to not contribute to inequities and how to help in that regard. So a few recommendations and ways to think through this. So on the next slide. Oh, sorry, I missed one slide. Let me talk you through this first. Go ahead, you're right, I was ahead in my mind. Patient prioritization, let's talk about this. So when we think about this backlog and all of the patients who maybe missed screening, it is important to start to think about how do we prioritize patients. So here's a few ideas and recommendations around how to think about which patients should be screened first. So number one, I would actually put a number one above what's listed here. And I think number one is to really look at populations that have higher cancer rates and maybe lower screening rates overall, right? So we know that populations that need help navigating and getting engaged in care around screening without the pandemic definitely need help getting engaged in care and get their screening done during the pandemic. So let's keep that front of mind as well. Then any patient who has symptoms, of course, I would say doesn't actually qualify as screening, but that patient needs care and needs a way to get engaged in care if they're having new concerning symptoms that aren't going away. Anybody who had an abnormal screening test before the shutdown and before the pandemic really started and needs to be scheduled for diagnostic evaluation, that's another patient group that should be prioritized. Anybody who's needing, the additional procedure beyond, like a biopsy or other procedure beyond their screening and diagnostic evaluation, should also be prioritized as we think about dealing with this backlog. And then people who fit high-risk categories, for whom regular screening is a higher priority anyway, just due to their higher probability of disease, also would be important to prioritize. And that would include people that we know are higher risk because we have good information about their family history in our electronic health records, as well as people we know are higher risk because of other characteristics and parts of their life, which I would say includes socioeconomic kinds of things, as well as race and ethnicity. And then anybody who's asymptomatic, but behind an adherence. So people who are overdue for screening, should probably be prioritized over people who have been really regular with their screening, and maybe could delay a year with no adverse effect. And then people who are newly arriving to age of beginning screening, should be prioritized as well. So people who are ready to engage, the COVID rates are low, their health system is up and functioning, and they're looking to start their preventive care and screening. We want to make sure that they have a way in to get their screening test done. Okay, so the next slide is some recommendations about just thinking through, again, like that there may be patients who could safely postpone a screening test until a later time. So it's important to recognize this, that there's, the screening discussion with patients is highly nuanced, as we know. But think about this example. So for many women still get an annual mammogram, and that's appropriate. But remember that for women who are age 55 or older, who are average risk, have no signs or symptoms of breast disease, have had a history of normal mammograms, it may be appropriate to delay and have a mammogram every 2 years, which is still part of guidelines, right? So that includes the ACS guidelines, as well as US Preventive Services Task Force guidelines, that say that women 55 and older, average risk, no new signs or symptoms, no other reason to think that they're at higher risk, that having a mammogram every 2 years may be appropriate. And so then once things are back to normal, those women who could either go back to an annual screening schedule or continue screening every 2 years. That's a conversation that should happen between the patient and their healthcare provider, but it's important to recognize that depending on what's going on with the patient, there may be opportunity for women to recognize that they could go to an every 2 year screening schedule. The other thing to remember is cervical cancer screening guidelines have changed, right? And they've changed, over the years, but lots of women are still getting cervical cancer screening probably on a too frequent basis. So recognizing that may be another option to just re-educate people, both healthcare professionals and patients, about the current guidelines, and that every 3 to 5 years, depending on the test used, is guideline driven and appropriate right now. And then I'll also mention just the importance of thinking about the use of stool testing for colon cancer screening for populations and people at average risk also. And that would be another good option and way to engage in screening amidst the pandemic. And then I guess I'll also mention the important part of recognizing that there are reasons and times to stop screening. So people who are at advanced age or who have other life-limiting health issues, that may be appropriate to cease screening. And that's an important discussion with the healthcare provider again. Okay, next slide. And so how do we talk to patients about this? So I think there's a couple things to keep in mind. And I've seen health systems are doing this, but just some reminders and kind of summary points about how to talk to patients about how to come in for screening and the importance of it, and how to reassure people that health systems are taking precautions to keep patients and staff safe. So remember that most, especially now, this slide may be a few months old. I think this is all evolving so fast, but most facilities, and maybe every facility, I could change this to say, is pre-screening for any symptoms of COVID, either before the appointment itself with a phone call, or certainly on arrival, and checking temperatures and making sure that no fevers are entering the building. Everybody's wearing masks, or should be, and that makes a big difference, as we know. Lots of places are, changing their traffic patterns, so there's different entry points and different exit points, and really keeping the patient flow in a way that it minimizes close contact and maintains appropriate distance. That scheduling is changing, and that waiting rooms are no longer as crowded as they used to be. There may be fewer available appointments, or they may have patients waiting in their car until they're called in. but those are also ways that health systems are, ensuring that people are as safe as possible. And then of course, a lot of endoscopy centers or other procedures that may be a part of the screening and diagnostic process may be requiring and doing pre-procedure COVID testing, actually, just to ensure that there's no asymptomatic COVID going on at the time also. Okay, I just want to leave you with a couple of resources. I think that's next. Yeah, so this, I think you may have looked at this earlier and hopefully you've seen it. This is posted on the ACS, Comprehensive Cancer Control Technical Assistance website, but this is a guide about returning to screening safely during the COVID-19 pandemic that we recently released. And so thank you, Ali. There's the web link there, and the links are in my slides too. A guide that includes these kind of 4 key messages, and then I've just shown screenshots of the breakdown of colon, breast, lung, and cervical cancer, the sort of 2-pagers that are in the guide. So if you're coalition member or a healthcare provider and you're interested in focusing on lung cancer screening, you can just pull out that 2-pager on there. But there's a few key messages I'll just go through that are, I think, summarize these issues well and help us keep our focus. That we want to remember that cancer screening remains a public health priority despite the challenges we continue to face during the pandemic. Without deliberate focus, we are concerned that screening disparities could be worsened. And so we want to keep a really deliberate focus on not worsening screening disparities as a result of the pandemic and making sure that we're reaching populations that are due for screening, overdue for screening, or who face additional barriers to getting their screening tests done. The importance of effective and trustworthy messaging to engage patients in the resumption of cancer screening is also an important takeaway here. And that we really need implementation of new processes and policy changes to sustain access both to primary care as well as access to screening. And that's policy levers at really all levels, like institutional policy where we change workflows and other processes all the way through the state and up to the federal level to really ensure and support sustained access to care. And the next slide, just in case you haven't seen it, but also we have a COVID-19 and cancer kind of hub on cancer.org that's continually updated. So be sure to check there if you're looking for new information or updated information about the impact of COVID and cancer. Excuse me. And then I think that's it. I have one more closing comment on the next slide. Just a reminder, I've said this a few different times through my time speaking with you here, but I think just the importance of remembering that really no one should be disadvantaged in their fight against cancer, and that we want to keep a health equity lens to all of the work that we do and how we resume screening, how we help people and health systems navigate these times, recognizing that those who face additional barriers need additional support, and then we want to keep our focus on that so that we don't exacerbate disparities even unintentionally. So I appreciate the time together. I know we'll have some time for questions, and I'll look forward to that.
Well, great. Thank you so much, Laura, for your presentation. And so let's move on to Linda Oberholzer. So Linda, thanks so much for joining.
Hi, thank you for the invitation. Can you hear me okay?
Yes, we sure can. And I saw you adjusting your camera, so I want to tell you are on point. Look fantastic. We're ready to go.
I only got the camera put on here. I'm in a different room and it just got put on like 5 minutes before the session. So, all right, everything seems good. Well, thank you very much for the invitation to speak today. And so what I'd like to do today is just kind of review some of the changes that have happened with this COVID-19 pandemic and the perspectives from the clinical setting, and from the other notable thing is from primary care. I'm not an oncologist, however, we do get very involved with cancer screening and follow-up care, so I'm going to be talking a little bit about that. Next. I just really wanted to quickly review conflicts of interest. Next. So for my objectives in this part of the panel, again, I just wanted to outline some of the major challenges and some of the big themes that have been happening in clinical care as a result of the pandemic. And to talk a little bit about some lessons learned, I'll review a survey with some work that's been done by a colleague of mine here at the university. and describe our experience in an academic medical setting and from the literature on ways to overcome some of these challenges. Next. So, you know, as you've no doubt heard all day today, this is in about March of this year, we started hearing about this new virus that came into the United States and we really started hearing it here. I think the first case here in Colorado was in March. Next. And then here is an article from June and just describes more of the community spread. And around this time, what we were seeing in the clinic, so it was right around March in the clinic that we were kind of waiting with bated breath to hear, you know, is this going to be something that's going to hit us? Keep in mind that with SARS and MERS, excuse me, and even H1N1, we've had virus epidemics before, and of course every flu season. This one was a little bit different, and it became evident pretty quickly that this is something we're really going to have to prepare for. And it was in March that our clinic, and I think most clinics, started really having conversations about how are we going to prepare for this? What is our testing protocols going to be? So some of the things that we did is we started having town hall meetings involving the entire Department of Medicine, as well as the Division of General Internal Medicine, and of course, waiting to hear what the guidance. And I will tell you from my perspective, the guidance changed just about every day as we learned new information. Remember, in the beginning, it was really hard to even get tested. Next. And then this is an article, Dr. Ernest is our division head, and he published this in the New England Journal of Medicine on becoming a plague doctor, because I don't think any of us that are in training, you know, we're trained to learn about situations like this, but it's thankfully not that often that we actually have to live through something like this. And I remember one of the first patients I saw back in March who had just traveled from Europe, and we were just getting our protocols in place and getting our PPE in place. And when someone shows up, okay, here we have a patient who has risk factors for COVID, and this is really our first test of how we're going to handle this. And Dr. Ernest wrote in this article about, you know, the need to mask up and put on all of this PPE, the effect that can have on caring for our patients. And it really resonated with me because I remember that patient that I saw, you know, we had to mask up and put the face shield and the goggles and the mask on. And when I walked in the room, she just broke down in tears. I think it was very scary for her. And I felt horrible. And the point that Dr. Ernest makes in this article is, you know, maybe at the end of the day, it's nice that we're still able to do that. But I will say it's quite a change in how we practice and just having that face-to-face contact. Next. So some of the major themes, and we think about the pre-COVID-19 era going into this now post-COVID-19 area, some of the major themes that have come out is this rapid adoption of telehealth. We were doing a little bit of telehealth before, but pretty much it felt like overnight was adopting telehealth. And how do you change a big practice to prepare for that? Also, another theme of rethinking how we do clinical care, I think this was touched on in some of the earlier presentations, is how do we keep our staff safe? How do we keep faculty safe, that we have a workforce to help patients? How are we going to work through the check-in process? How are we going to think about the referrals that we make? And then the last point I wanted to touch on just a little bit was the real need for collaboration with our public health colleagues. I think there's perhaps no better example than a time in our lives when it's so important for everyone on the ground in medical practice to really be collaborating with and reinforcing and having consistent messages with our public health colleagues who have done really excellent work in preparing us. Next. So I'm going to spend the most time kind of talking about the rapid adoption of telehealth, because this really was a sea change. Telehealth is not new. It's been around for a while, but really sparingly used. It was originally conceived as a way to reach out to populations who lived in more rural areas to overcome geographical barriers to visits and to reach out to those in medically underserved areas. And legislation to support this goes back as far as about 1997. And there have been every few years, there's legislation that changes that a little bit. But as originally conceived, you had to be, as a patient, you had to be in one of these target populations. So living in a rural area or living in a medically underserved area, such as a health professional shortage area. And that's what allowed providers to get reimbursed for that practice. Initially, I can remember early on when telehealth started, it required the patient to, at their site of the telehealth visit, to actually be at a site of care with another provider. So it was almost like a provider to provider visit with the patient there. But there were, suffice it to say, there were a lot of requirements that had to happen for that to get covered. And most recently, when March of 2020 rolled around, there was legislation that was passed, the Coronavirus Preparedness and Response Supplement Appropriations Act. And what this did was really allowed providers and practices to remove certain requirements for Medicare reimbursement. Not that Medicare is the only insurance, but a lot of insurance companies do tend to follow what Medicare does. So examples of that would be covering telephone visits as a form of telehealth outreach, allowing patients to be seen at home so that they didn't have to come in to a facility to have that telehealth visit. So there were a few examples like that. It allowed for us to be able to bill for telehealth visits with some requirements for documentation. And there were differences between doing a telephone and a telehealth visit. So those are still around and went into effect, as I said, in March of 2020. And as far as I know, these will remain in effect until the pandemic is considered over, whenever that may be. Next. So how common is telehealth in practice? I can tell you from personal experience, and I think this is true with many of my colleagues, telehealth was available. It was an option for us prior to March of 2020. I don't think any of us were really doing a lot of it, and I don't think there was a huge demand for it either. This graph comes from a study that my colleague, Dr. Amy Hipschman, has done. It was a survey that was adapted from a telehealth survey from a few years ago about use and satisfaction with telehealth. And she adapted it and included items about perceptions of disparities. So this work was really ultimately leading to, do we think that the use of telehealth in any way makes disparities worse? And are we really reaching the people that we need to reach? So this was some of her initial data. And I thought this slide was very striking. On the vertical axis, you'll see there the percent of telehealth visits. And then in the two bars, you'll see on the left is prior to COVID-19. And then on the right is during and after COVID-19. And the darker blue areas are the percentage of visits that providers were doing using telehealth. And you can see, whereas before COVID-19, the majority of providers were never did a telehealth visit or very rarely. And on the right, all of a sudden, you go from 76% of providers never doing telehealth to now about 80% of us do. So all of us have done it now, like I said, pretty much overnight. This is a skill set that we had to learn. Again, it was available to us, but there was really, I don't think, either the demand or the push on the provider side to do these. And this was a survey done here with general internal medicine, psychiatry, and the seniors clinic. Next. So some of the factors that necessitated this rapid adoption of telehealth, and I really think this is going to be here with us to stay, and I think it's going to really rethink everything we knew about healthcare delivery is now going to have to be adopted or thought about in the context of telehealth. So on the left here, I've addressed some of the drivers. So why did we go to telehealth? The most obvious one was to try to keep in line with the recommendations that were being put forth for social distancing and the need to isolate from those who might be symptomatic. So it definitely reduces barriers for any kind of physical access and can replace an in-person visit. It also allowed us to safely triage, or it continues to allow us to safely triage patient if someone calls in and says, you know, I'm having a sore throat or a cold, or I was exposed to somebody with COVID, we can safely triage that patient, be able to see them and decide if they need to go in for more urgent or emergent care, or if they can go ahead and be treated as an outpatient. I think some of the additional drivers, although this certainly wasn't the primary reason, but I think some of the original drivers were also, if you think about the costs associated with having to come in for a visit, if you had any kind of commute, if you had to take time off work or get childcare, it can decrease some of those costs. Although the childcare piece, we now know that a lot of people are really struggling with having that childcare at home. But it does potentially decrease some of those costs. It also allows for flexibility of practice teams to work remotely and adhere to physical distancing guidelines. So when this first hit in March, we kind of we never have completely shut down. So clinics, and I think this is true for any clinic, still stayed open because you're still going to have patients who fall and scrape their leg, or someone who is elderly, who is dizzy and needs to be evaluated. So you're still going to have those things that happened. But pretty much overnight, we went to virtually all telehealth, and all of us were doing telehealth from home. I can remember a morning in March when I actually was sick myself. We had COVID and kind of wrapped up in a blanket and doing telehealth from my basement. That was my first experience. It also allows us to maintain contact and communication with patients. So certainly you can do a lot of this work over the phone, but this is another way, and I think patients appreciate this, and I think it's substantiated in the literature. It is a way to kind of remain face-to-face. Some of the challenges, there are a lot of barriers. The biggest one I think that's been reported and that definitely we've witnessed are, this talk about the digital divide. If someone doesn't have a computer or an iPhone or a platform that supports being able to use telehealth, if you don't have reliable internet, we've all heard stories about students having to go to a parking lot of, a McDonald's or a Walmart and Zoom into their classes that way. So what is the impact then on healthcare, and what kind of new potential disparities are we going to run into? Language, we do have a way, we have a good workflow for having interpreters, and now we have a way that we don't have to have interpreters come into the building to physically accompany someone to visits. But how does that work now with telehealth? And the more people you invite into that visit, what does that mean for privacy? The SES is the socioeconomic considerations. And again, I've mentioned some of that. If someone doesn't have access, if they have a lower economic status, if they have a computer, but they can't afford, the right platform or a lot of internet. And then the elderly, I have an 88-year-old father, and I can't imagine he's not going to be able to know how to do a telehealth visit. So a lot of these people are still, whether it's preference or whether it's just out of necessity, are still going to have to come into clinic. It also presented pretty much overnight, and this workflow has changed pretty much weekly. There are workflows that we have to accommodate this, everything from checking a patient in. It's a new workflow for the medical assistants and the front desk staff to check people in. We're much more dependent now upon technical factors for a successful visit. So it is challenging. It takes a little bit away from just strictly having to be able to have a conversation about the medical issue at hand. Now it happens that there's just going to be some technical glitches, and every once in a while you just you know what, we're going to bag it and I'm just going to give you a phone call. Clinical decision making may have to be done based on different information. And what I mean by that is there is some value to having people come in for a visit. If you think about, I had a situation come up where someone was in for a physical exam when things opened back up, and we were able to come back into the clinic again, not having any symptoms, doing well, but lo and behold, irregular heart rate and a new diagnosis of atrial fibrillation. So what kinds of things, you know, might we have to be doing differently because it's a telehealth visit? It does not entirely remove the need for in-person care. As I mentioned, there's always going to be a need for some capability just to see people. If anything, I think in a primary care setting, what we've witnessed is that, you know, I'm hesitant to take care of this because I don't want to go to the emergency room. Is this something I could take care of in clinic? And there's literature to support that. We have also heard evidence when we had the big outbreak in New York, when they were the epicenter of people who are avoiding emergency and urgent care. That's true for, I'll speak about this a little bit with cancer in a bit, but also for all those non-cancer situations, you know, strokes and heart attacks and things like that still happen. And what I think it means for us is you have to learn to more urgently triage things. And there may be things that you have to do in an outpatient setting that you have to get kind of creative. How can I keep them out of the emergency room? And then one thing we've noticed is decreased uptake in telehealth compared to in-person visits. And if that's happening, even though it's available, doesn't mean that a lot of people are going to participate. That does have a huge impact at the end of the day on, any kind of medicine, like it or not, is a business. And it does have important financial implications if you're not seeing patients every day and taking care of them. And when we were doing only telehealth, we would notice that our schedules just would not get filled up in the same way. Next. Just a little bit of a word here about disparities, because I think this is going to be a huge theme, and I think this is going to create perhaps a new challenge to think about when thinking about disparities. And I know this has been mentioned previously, but there are healthcare disparities out there. How can we avoid making this worse? So from that survey that I mentioned, my colleague did, anywhere from about a third to 3/4 of survey respondents, and this was primarily providers and staff, agreed with the concern that telehealth could worsen health disparities during COVID. There was a very interesting article that was done with the World Health Organization. It was a worldwide population-based study looking at 75 different countries and like billions of patients in that registry. And this was a study that was published back in 2016, but it looked at changes before and after the 2008 economic recession. So I think there's lessons we can learn from that. But what they looked at, and this wasn't cancer specific, but what they were seeing was that there was an excess of 263,000 to 313,000 excess deaths from cancer. And this analysis was specific to cancer right around that 2008 to 2010 time period. And keep in mind that that was just based on purely economic context. Now we're dealing with a pandemic where there are some public health context. But I think going in line with that public health context is now the financial implications. And because that has such a strong implication for health disparities, it's a little bit of a scary situation. And we know that individuals with a history of cancer, what does that mean for cancer patients? Individuals with a history of cancer are already susceptible to a disproportionate burden of financial toxicity. So it's something that I think we'll really have to be thinking about moving forward. Next. So some of the recommendations with this survey here that was done to reduce telehealth disparities, changing infrastructure, and that means if there is a way to support, if someone doesn't have a computer or internet access, what can we do to support them in that? Can we provide them with an iPad or something like that so they could go to a designated place and we could have something available. Support for clinicians, so that we can be mindful and know how to use telehealth appropriately and perhaps screen patients better and learn how to do it better. And then training and educating all stakeholders, because there is a lot of training. And if you're not able to provide the same level of training, that's another point at which disparities could persist. Next. So switching now to some of the more clinical care, as has been already mentioned today, individuals with cancer may be at increased risk for morbidity and mortality related to COVID-19 compared to those without a history of cancer. That is very much dependent, what we're finding, on what type of cancer a person has. For example, someone who has been treated for head and neck cancer or lung cancer may have a very different susceptibility profile than someone who was treated for an early stage breast cancer or cervical cancer and all they needed was surgery perhaps. So there's those types of things to keep in mind. If someone has had a splenectomy, for example, or if they're on medication that may suppress their immune system. So just because someone has had a history of cancer doesn't necessarily mean that they're immune suppressed, but you really need to, that's not the same for all cancer patients. Use of telehealth may help to reduce the time to diagnosis and treatment, as well as access to care. There are several publications. I think as much as we can use telehealth, and I think it was brought up in the previous talk, we ought to be using telehealth very intentionally and using it in a way that doesn't propagate healthcare disparities and getting that care to people who really need it. I will say, as far as the clinical care that was happening, I'm coming from a primary care perspective, and I kind of mentioned how initially there was a very significant drop off in our patient volume. People were just afraid to come in, plain and simple. In the cancer care settings, this was not true. They might have had a slight decrease. I think our numbers here, where they were still seeing about 75 to 80% of their patient volume, while our volume dropped quite significantly. And that is true. You could talk about different, cardiology, ear, nose, and throat, all of those different departments, I think, saw this effect differently. Next. In the oncology settings, the literature that's out there, telehealth has certainly been a theme for them, but I've seen strategies include things like virtual tumor boards, virtual multidisciplinary clinics, converting, keeping some of the in-person visits, but then doing supportive care in a virtual manner. There is guidance out there. I'm most closely familiar with NCCN, but I think, it wasn't intentional, but I left ACS off of here, but ASCO, I know Cancer Care Ontario was one of the early institutions to come out with, okay, what is our plan for managing cancer care? And most of the suggestions seem to center around modifying treatment regimens. So can we, if someone's getting radiation, can we dose it differently so they're not having to come in quite so frequently? Could we modify so that we use a treatment regimen that doesn't require as frequent infusion, for example? And sometimes you have to ask the question and assess whether treatment can be delayed without risking an increase in morbidity and mortality. An example that was brought up here in the literature was something like ductal carcinoma in situ, for example. That's going to be triaged when it comes to treatment. That's going to be triaged a little bit differently than someone who has a stage 3 breast cancer, for example. So you have to kind of think about that. I talked a little bit about the modifications, including adapting telehealth to meet needs with virtual tumor boards. And most of the published work I've seen really talks about those going through active cancer treatment. And you heard a great talk just before me about cancer screening. But what about those who have completed active treatment, including long-term survivors? Next. And, there hasn't been a lot published around survivorship, but I think, we were already struggling to maintain that collaborative care and the need for long-term surveillance and monitoring. And I think some of the concern is, okay, now we're talking about surveilling for late effects, and that may not perceived as something that's as essential as obviously getting cancer treatment or getting a diagnostic workup completed. In the primary care setting and in the oncology setting as well, the workforce right now is just really at capacity and competing demands when you're dealing with a pandemic and the workforce issues. We've noticed this in the research field. It's really hard to grab those providers' attention. So if you're asking them now to take on something that they weren't used to taking, there is a publication out there that interestingly described how oncologists may have to take on some of that care that we were telling them, okay, now we should be collaborating with primary care. But if I can take care of something in one setting, I probably should be doing that. And that's just one of the ways where we might have to think about care. Efforts for health promotion may be adversely affected. There's literature out there to support that we've seen increases in the use of alcohol. It's more difficult to maintain exercise regimens, for example, if someone was going to a gym. Next. I put a picture of an elephant on here because the big elephant in the room, and I think this is definitely true in survivorship, are the psychosocial stressors that we're experiencing right now. We have seen a tremendous need for referrals and assessments, and people are just stressed. And this goes for not only patients, but also healthcare providers. Already periods of transition can be especially stressful, but trying to do that during a pandemic may just be too much. We've seen a marked increase in visits related to psychosocial concerns. As I mentioned, this may be a time for relapse of unhealthy habits if someone was making progress as far as smoking or alcohol. And mental health can be affected by financial toxicity as well. There was another interesting article here that described in Europe and North America, again, looking at that 2008 time period, that they estimated there were about 10,000 excess suicides just related to the stress around that. Next. And just a word about collaborating with public health. And I think the points I wanted to make here are that, again, probably no more than at any time in my career anyway, and I think for most of us, have we had to really rely on our public health colleagues for good, consistent information, testing, where to go to get tested, who needs to be tested, what's the data coming in from other countries, defining a case definition, and so that we can be really mindful about triaging the patients that we're seeing. And I think especially we've seen it play out. It's been really eye-opening just to see how much of a need there is for reliable and consistent messaging. So we need to be very consistent with what our public health colleagues are recommending. And I just put a bullet in here about, again, I think we've seen this play out. What about the role of public trust and misinformation, and especially in populations that might have been disadvantaged or underserved? I think there's a lot of area. If anyone does work in that area, I'd be very interested to see what's going to come out of all of this and how we can overcome that. Next. So I think that's it for me. And I just include this picture because, you know, it's hard to get sometimes like children to learn about why they need to have this mask on. And so we've had to try to get creative, but please do wear masks and stay safe. And if anyone has any questions, I will be happy to be available.
All right, awesome. Thank you, Linda, so much. I love that picture of she's a fun kid, and I think a really great reminder about all of our roles in thinking about the pandemic and health. So thanks a ton. So I think we will move to our next presenter, and we'll wait for questions for both Laura and Linda, but we'll go ahead and continue on. All right, so moving ahead, and I agree. Thanks, Linda, for the presentation. Okay, are we good? Making sure we can hear you.
She just came off mute.
Can you hear me?
We sure can. Okay, very good.
Okay, great. First of all, I just want to introduce myself. My name is Erin Buss, and I am so thankful for the opportunity today to share with you my cancer journey and what that looks like, and hopefully to shed some light on what it means to be a patient that was going through cancer treatment prior to a pandemic, then the introduction of a pandemic, and then full-on pandemic mode. So in order to do that, I'd like to just go through a little bit about where my journey started. So next slide. This is my diagnosis timeline. On March 15th of last year, I palpated a lump in my right breast. I knew it was probably in my best interest to reach out to my physician to talk to her a little bit about it and whether or not diagnostic imaging was needed. We agreed that it was not only a good idea, but necessary for me to schedule diagnostic imaging just based on my family history and some other screening history in the past. And so thankfully, I was able to get in for a diagnostic mammogram just a few short days after on Thursday, March 21st. At that time, I realized that not only did I have a mass, but I also had one questionable lymph node that was happening as well. And so quite quickly into my journey, I realized that this probably wasn't good. And so we moved very quickly and the whirlwind began. So I did have my biopsy the following Monday on March 25th. The next day, I knew I tested, or the pathology came back positive, and the diagnosis was invasive ductal carcinoma grade 3. Later in that same week, I found out that I had triple positive breast cancer. Next slide. So as any cancer patient can relate to, and healthcare provider or anyone that's working with a cancer patient, a newly diagnosed cancer patient, you know that here marks the tests, the scans, the labs, and I immediately started with my workup for my breast cancer diagnosis. So I went right into a breast MRI, had a clinic visit to do labs. I found out at that time that my tumor markers were relatively low in the grand scheme of things. I did have a CT scan. Unfortunately, on that scan, they did notice that I had a lung nodule, a spot on my liver and my pancreas. So that vetoed the bone scan and sent me right to PET scan. Because of what we knew about the kind of disease I had, I needed to get baseline cardiac tests and my port placed. And then I did finally get that PET scan. And thankfully, all those suspicious spots returned benign. Next slide. You know, while you're going through this, your head is spinning. You're just trying to take in a lot of information. And quite frankly, it's taken me a couple times to look back to remember exactly what the journey looked like. Because as a patient, you just put your head down and you do what you need to do. And so with my mass of my tumor and my positive lymph nodes and what we know about triple positive breast cancer, it was determined that I would need to start neoadjuvant chemo, which was TCHP, and I would have 6 rounds. I also made the decision that I would have a double mastectomy. And after I finished my 6 rounds of chemo, the pathology came back from the surgery that I had a good response, but I didn't have a complete response. So what the data now shows is rather than going to HP, I would need to have 14 rounds of Kadcyla. Because of the triple positive status, I did make a personal decision to have a complete hysterectomy. And then again, because of the size of the mass and the lymph node involvement, I would need 25 rounds of radiation. Next slide. And this is when things started to get interesting. At the end of the year, while I maintained pretty good health and had the normal treatment-related toxicities, at the end of last year, I really started to feel the treatment play its toll on me and my body. And so we started seeing that I was having consistent low ANCs, white blood cells, magnesium, potassium, and I was having elevated liver enzymes. January 2020, I started experiencing very severe muscle pain and neuropathy, really unexplainable. It sent me to the ER twice. Wasn't sure what was happening. And so my oncologist and medical team just continued to watch me closely. We did do some dose adjustments with the Kadcyla and some treatment delays. In February, because of the consistency with my low white blood cells and the dose adjustments that were needed and the delays, my oncologist determined I would need to have a bone marrow biopsy to rule out MDS because of my exposure to platinum chemo with the TCHP. And this is when we just started hearing a little bit about COVID and what that meant. But prior to that, because of my risk for infection, my oncologist and medical team really strongly encouraged me to be very careful about my exposure because we were in cold and flu season. And so really, before COVID became a main part of our conversation, I started taking precautions to protect myself and my health the beginning of March. And so, and then I also did get my bone marrow biopsy results back, and I didn't have any specific abnormalities. What we were seeing was just treatment-related side effects. And I did continue to have low white blood cells. And because, again, of the time and the surfacing of COVID, it was thought that I should start to receive Zarzio shots to support my white blood cells. Next slide. Hello?
Yes, we can hear you. Erin, do you see, it says my journey, what is COVID? Is this good, or do you need the next slide?
Well, I just lost actually the screen. Oh, there we go.
Okay.
The next slide, please. Okay. So as I mentioned, and as we've heard today, the next one, the my journey, what is COVID? There we go. Thank you. I really started getting a lot of mixed information on what COVID was and what was the risk to me as a patient going and undergoing treatment. And so, as you can imagine, this is really unsettling because not only did I know that I was at risk of a regular infection, now there were these conversations of, you know, what is COVID and how is that going to impact me? And, you know, how concerned do I need to be as a patient? And really in mid to late March, I started to see the clinic and the staff really start to take precautionary measures. And as a patient, you know, I was going into the clinic quite frequently just because of the treatment-related toxicities in the labs that needed to be done and how closely they were watching me. So to see some of those changes happen in the clinic, it was a little alarming, and it did remind me that I really needed to be careful and to be safe and to take all the precautionary measures that I could in order to keep myself safe because I knew I was at risk. And so what I did start noticing is that, you know, masks were being worn by all the patients and by all the employees. They were doing COVID screenings upon entering the clinic. And, you know, a lot of the questions that were being asked, you know, were a lot of questions that I were feeling, you know, or have you had chills, body aches, things of that sort. Well, yeah, my treatment can cause that. So, you know, it would cause a little bit of paranoia. Is this normal treatment related issues of being a cancer patient, or is something more going on here? So the other big noticeable difference was that no visitors or caregivers were allowed into appointments or into the infusion center. You know, and I went from, with my neoadjuvant chemo, I was so lucky to have such an amazing support crew that, you know, I would have friends drive me to my appointments, sit with me through my infusions, and now that was no longer available to me. And so you could see how it was not only impacting me, but also impacting the other patients that were in the clinic as well. I did see that the clinic did start working initially sort of on this like skeleton staff. There wasn't as many bodies in the clinic. If employees were able to work from home, they were allowed to work from home. And then again, as you heard, this was the biggest introduction, or the first time I saw the introduction to telehealth. Next slide. So I just thought I would talk a little bit about what my personal impact or how COVID has impacted me and my treatment regimen. And what I noticed initially is that my medical oncologist and medical team really started to pay even closer attention to how my toxicities, my treatment-related toxicities were impacting my body. And we would have a lot of conversations about, you know, is this worth the risk? Would we need to do a dose adjustment? Would we need to do a delay? Would we need to do an interruption? What sort of supportive medications did I need to come in on so that we could continue treatment and support my body to be able to potentially fight an infection if it were exposed to one? Again, I mentioned this earlier. Now I started not only was I not feeling well, but I had to take on the responsibility of getting me to the clinic and to my appointments and to my procedures. Again, my support staff or my support crew here in Denver were really awesome. And I relied on my friends to help with just running everyday errands, grocery shopping, anything that they could help me with to help me not have to go out into the public and potentially be exposed. Mental health in this time, a lot of anxiety around the unknown. It certainly did create even more isolation. I think when you're a cancer patient going through cancer treatment, you already feel a little bit isolated, but now you add this layer on top of it and it adds even more to that feeling. As well as I started to notice again, and watching newly diagnosed patients and just feeling sad for them and worried about them as they were going through the initiation of their, or the start of their cancer treatment, and seeing just the differences in the infusion center and what that meant for them. Some of the supportive care services that I was taking advantage of weren't available initially. I did acupuncture throughout my whole journey. In March, that wasn't available to me because we weren't really sure, if the benefits outweighed the risks. Again, the same was with massage, Reiki, and counseling. And just the fear of not knowing how this would impact my work was very real too. Next slide. Lastly, these are my suggestions. If you know or are supporting any patient through their treatment, and we've heard a lot about this today, but just really paying close attention to mental health and offer ways to support with anxiety, isolation, and fear. Ask or create ways to connect while maintaining appropriate COVID precautionary measures. Let the immunocompromised individual take the lead and be supportive of their decisions and their comfort level. And just don't insert your own opinions on what you think COVID is or how you might be able to help those patients, whether or not you believe in the severity of it or not. And then also be willing to quarantine if a patient needs additional support. I think that is one way to really help them feel safe and to feel supported. If there's anything that you can do to help reduce risk, I had really great friends who delivered me groceries. They wiped down the groceries. We had a designated box for the groceries. I had meals delivered to me, prescriptions picked up for me, and other errands ran as well. And I think always, no matter what, it's just always important to ask, never to assume that you know what a patient needs during this really difficult time. So I hope that did help shed some light onto what it feels like to be a cancer patient going through these crazy times. And I think we're ready for questions.
Yeah, awesome. Well, thank you so much, Erin. That was a fantastic, and I love, if we can actually just go back to that last slide really quickly. I really love how you, ended with what are some of the things that you would recommend that providers, public health individuals really think about. And I'm going to start off with a question while we get folks coming in. And I think Becky and Christy, we have until 4:30. Is that correct?
Yes, 4:30 for questions for this, and then we have a few closing sentiments after that.
All right, fantastic. So Erin, let me start off to ask you, I think earlier in the day and throughout, there's been the question about how do we really think about that balance between people who are immunocompromised or people who are really thinking about even their health in general, who might be patients who might not even be immunocompromised, but just thinking about that risk versus that benefit, which I think you speak to here about getting preventive screening or going to appointments when you have to absolutely, when maybe there's no alternative for telehealth. I guess when you're thinking a little bit about this, I think the point you've made about every person is different and every person has their own beliefs, that individualistic care, I think we've heard today too. But I guess, I'm sort of toying with and making sure that my question comes in. But I think that in terms of us communicating from healthcare providers to public health professionals about that risk versus benefit, do you have any specific ideas or thoughts about what people really should do in their messaging to patients?
I can tell you that from where I'm at now and where I was in March with the introduction of COVID in, my cancer journey and my treatment, I'm a very different person. I'm much healthier now. When I was being treated in March, I was dealing with a lot of those treatment-related toxicities. I felt terrible. And so the risk to me then felt really high and felt really scary. And so, but as I continued to move through my treatment journey, and as we really determined how to support me and how to get me into a place that I was feeling better, I changed sort of my strategies about who I would let into my circle and what I felt comfortable with, because I do think I am a believer in holistic health, and that mental health and connection and support is really important to our overall well-being, especially for anyone, but especially for a cancer patient. And so as I started to feel better, I started to open up and get support from friends. And so I really think, to answer your question, it is going to be so personalized and it's going to be so individual. I don't know that it isn't a cookie cutter. I think as providers, as public health workers, it's just about engaging into the conversation and, getting that patient talking about, what is important to them, what are their priorities, and how can you help support them the best that we can. And so, unfortunately, I don't think it's a black and white answer. I think, it's going to be a lot of different answers for each individual.
Great, and I think that's super helpful. And then I just want to ask folks that if you do have a question or if something that you want to voice, just let us know in the chat, and so we're clear, so I don't overrun talking to someone who's trying to present as well. Laura, let me ask you this: as sitting where you do and the work that you do with ACS, seeing the screening trends and seeing the change in care and what we're looking at, Laura, do you think there's some specific policy shifts that we're going to see now as a result? I know throughout the day that we've talked a little bit about policy and where things are going, but in terms of the preventative cancer sphere and looking at how things are changing, we've talked about telehealth will be here to stay. We'll see some other practices. But Laura, I guess, do you see any other sort of policy movement or big trends based on what we've experienced in COVID for prevention and what we might see as even national policy or perspectives that might be changing?
Yeah, that's a great question, Andy. I don't know if I have much insight into what might happen nationally. I mean, especially where we are. So I'm not, I'd have to maybe pay me more to make some predictions about that. But yeah. But I think I'll tell you I have a couple thoughts on what I think we need. So a couple thoughts on things that I think need attention and do need policy levers and different or changed or better policy. One, I think this issue of insurance coverage and the employer sponsored insurance and unemployment is going to be huge. So Medicaid expansion, I think, is going to continue to be needed. And funding, of course, will be needed around that. But that, I think, is going to continue to be a big issue as we think about access to care overall, which includes access to screening and prevention. The second thing is funding for programs that support and serve underserved or uninsured populations, like the BSIP program or the colorectal programs for CDC. So CDC programs, I think that those levers need to be enhanced, and there's definitely ongoing advocacy on that. I would put HRSA funded health centers in that also as the place that we to help fill the gaps, and that they need ongoing support and funding. I can share kind of like very anecdotally from a small project that we are wrapping up with about 30 health centers across the country, that their breast cancer screening rates over the past 2 years aren't like 80% down, because remember, the breast cancer screening rate quality measure is women who've had a mammogram in the last 27 months. So I don't think their screening rate is capturing the full impact this year. The number is down from last year in this little cohort that we worked with. But what's more interesting and maybe more concerning is that the denominator of eligible women is up a lot. in the last year at these health centers that are across the nation. And I think that, I mean, I don't know all of what that is. Some of it's because HRSA's had funding for health centers to expand anyway, so their patient populations are increasing anyway. But I think the other part of it is I think people are seeking care, more people are seeking care at health centers because they're losing their insurance or they're becoming eligible for Medicaid. So that I think is probably the bigger issue in that. So those are a few thoughts on I think the areas where we need to focus on national and federal policy.
Awesome. Thank you for sharing. And I know we're getting a couple questions in, but I want to ask Linda one and then we'll jump. So Linda, I think you made a really compelling at the end of the presentation about the survivorship component and looking at the impact of COVID. And, you know, I think sedentary people, the weight gain, really looking at that. And we know that, of course, for reoccurrence, and then also even looking at the, you know, the things that cause cancer or the things that will cause a secondary cancer. So Linda, I think in that survivorship realm and that area of research, as well as what we're considering, so your thoughts about some interventions or what we should be considering at this point, or where, and you do so much great work in survivorship, Linda, in Colorado and at the national level. So I'm just wondering like what you think some of the provocative next steps might be in this area.
Well, it seems like there may be potential for, you know, I think as much as we can provide support, and I think one of the challenges is going to be, it may have to be taken to some extent out of the clinic setting. I mean, considering the financial climate that we're in now, you know, the lower adoption of telehealth, I wonder if some of that is because, you know, people are losing their employer-sponsored health insurance if they no longer have a job. So I think it would be an opportunity to explore perhaps peer support and peer-led interventions. I think that it might be an opportunity to really dig into that deeper and see if there may be a way to support that a little bit better. I think, you know, whatever kind of intervention, it's going to have to be, you know, being mindful of the restrictions that we have to have in place. So like, for example, the YMCA program, I know that was a huge program through Livestrong, but that's an example of something that just may no longer really be available. And it might have to be like an outdoor program. So I think there's different groups of people to engage. However long that's going to last, I think certainly addressing, like looking at the correlation between the mental health piece and the health behavior piece, because I think oftentimes they're so intertwined. But I think, I mean, the thing that kind of pops up, I guess, I mean, if I had the answer to that, Andy, I guess I feel like be able to help all my patients, right? But I really think the first thing that kind of pops up is there some way to really support and leverage peer support, because this is such a time, and it probably would have to be virtual. I mean, anything we do, I think, is just going to have to be virtual. And what new stakeholders could we reach virtually? And then being mindful of this whole issue with the digital divide. You know, for some people that's not going to work. So, you know, most people have a telephone. Would something more old school, just like a telephone. I think there is, you know, when we talk about telehealth, it's not just the visit that's done clinically or a billable encounter, but it's also, you know, sending information from wearable devices. So using apps and using patient reported outcomes and being able to send data from apps. So I would anticipate that we're going to see maybe a lot more of that. Those are just some thoughts that I have.
That's awesome, Linda, and I really love that. And I think putting back to Erin now too, I think to this point is Erin, and I think maybe even responding to Linda on some level, but Janice's question came in, is that if you participated in any support groups or programs, I know we're probably talking more about mental health, behavioral health, and where you got that support. But I do also, Linda, I love that idea of what does support look like, not, you know, for physical and emotional health and support. I think it's a really provocative idea. So Erin, with sort of that blend of Janice's question, as well as, you know, thinking about the idea to help support survivors, what's coming up for you?
Yeah, absolutely. I think I first want to preface this that just provide you guys with a little bit more background information, because I may not be seen as the average patient. My background's in community health and wellness, and I'm actually working on finishing my master's in public health. I am one class away from getting my master's in public health. And so, you know, I understand and have understood from the beginning of my journey how important, you know, emotional well-being, physical well-being, you know, that concept of this holistic process. And so right away out of the gates, I took advantage and had an amazing support team with my medical oncology team, and I got connected with a social worker. That social worker connected me with local programs that are available here in Denver. She also connected me with counselors that took insurance, and she had a very beautiful Excel spreadsheet that listed therapists and counselors and psychologists according to geography and insurance. And so I was able to connect with a therapist that was really great for me. That being said, since my diagnosis, I've had the opportunity to coach, unfortunately, those who have come after me. And so I've coached a good friend and former colleague up in Wisconsin who was diagnosed with rectal cancer at 44. I've coached, or am coaching a breast cancer patient down in Colorado Springs who was diagnosed at 35, and then as well as a breast cancer patient in Ohio that is in her mid 40s. And, you know, I can tell you that not all of those conversations, you know, I'm talking about the success that I've seen, the support that I've felt through mental health, coping skills, supportive resources. And I've seen that there isn't consistency with these other individuals that are going through their own cancer journey. And so I like that comment about peer-supported resources, because I think, you know, when I first was diagnosed, I was connected with a former colleague of mine and a friend who was diagnosed with hairy cell leukemia in his mid-30s, so really rare form of cancer. And he said to me, he goes, you know, Erin, we're now a part of a sorority we never asked to be a part of, a fraternity or a sorority we never asked to be a part of. And so I think when you are a cancer patient, helping another cancer patient, you really understand what's happening and the feelings that are going along with that. So, you know, support groups are so great. But in this time, I just didn't feel comfortable going to support groups initially in my cancer journey prior to any restrictions. I felt like I actually had a really great support system in my family, friends, and then the resources that I had available through my clinic. But I haven't in the virtual world. And so again, I think that's going to be individual sort of decision and preference. I hope that answers the question. Great,
I think so. And I think Chrissy also has another question in the queue. So thank you so much, Erin. That was great.
Yeah. To dive into that a little deeper, for the people that are in their treatment appointments alone, getting chemo for hours, what are your suggestions for how to pass the time?
It's a great question. So my TCHP took anywhere, well, the actual infusion was about 4 hours, but then, you know, there was the visit and then everything that happened after. So I was pretty much in the infusion center, you know, 4 to 6 hours every treatment. And so when I didn't have friends there, and when I started Kadcyla, that infusion time was a little shorter. I guess my, you know, if you schedule, like almost every infusion center has Wi-Fi available, I think it would be great for patients to schedule FaceTime dates with their friends. You know, you can put in your earbuds, your earphones, and you can connect with a friend while you're getting your treatment. And then that way you feel connected without actually having a person there. I think people have asked me what are some things to offer patients, you know, gifts, friends or family are newly diagnosed. I think suggesting, you know, Audible, books on tape, you know, anything that you can do to pass the time. You know, I still had quite a few conversations with my chemo buddies. You know, when you're on a treatment plan, you usually stay, like I was once every 3 weeks on a Wednesday, I had my chemo buddies. And so, you know, you can still connect with them. And I did have a good friend who, you know, even during the initial time of COVID, her husband was able to come in because of her stage and her disease, but I would sit with them 6 feet apart and just have a conversation with them. And so I think there are still really good ways to support patients, even though you can't be there physically.
I wanted to make a comment to Andy and Aaron, something you said about that. I'm reminded of, I thought they might have been piloting it here, but I've heard of centers. I think there's also opportunities to really think outside of the box. And I've heard the use of virtual reality as a way to people pass the time. I thought that was being piloted here perhaps, but I know there's people on our downtown campus who have that expertise. And I think this is a time to really kind of think outside of the box, and us as researchers or anyone who has kind of pull with, you know, policy or funding or research or from a systems perspective, it may be an opportunity to reach out to some new types of colleagues to think about something like that. Something about what you said made me think of virtual reality.
One of the current Cancer Fund grantees is using virtual reality for patient education. And so we're going to set up a virtual session for him to share all of that. But they've also used it for like education, for like, here's what your radiation first one will be like, and you can kind of go through the whole thing. And I don't know though, Linda, if they're doing it for the other things, but I know they're doing it for patient education.
Very cool. I love it.
Sound system and music. Yes, that's great. And I think you're right, Jamie, pediatric teams have used it. And I've seen it also in some of the elder care, I think even in care facilities where they're trying to look at better engagement for social and interaction and mental health too. So yeah, this is a really fun discussion, everybody. We're just a couple minutes out. I'm going to just go down the row and quickly I'd love to hear the final thoughts. So Laura, let's start with you. Just anything to close us out in this session?
Yeah, stay the course, wear your mask, and talk to your friends, get the social and mental health support that you need. And then don't forget about cancer screening last on the list, honestly. I think those are probably the best thoughts I have. Appreciate what you all do. Thank you for keeping Colorado healthy. And I'll look forward to seeing you in Colorado someday soon.
Awesome, thanks for joining. Linda, final comment.
I think I would echo wear a mask. I think in a situation like this where it looks like we may be in this for a longer haul for sure is, you know, taking it one day at a time, be kind to each other. That's as far as kind of getting through this, that would be my message. And, you know, we are still trying to be here for people, but it's just be kind to each other, wear your mask, and take it day by day.
Awesome. And to the panel before about that self-care and the like, really integrate that. Thank you so much. And Erin?
I would just say the same. You know, I think we are in this for the long haul, and as we get into winter, and for cancer patients that are going through treatment that aren't able to get outside as much as they can, and that was a place and space that they felt safe to do some social distancing and some connecting with friends, I would just encourage people to reach out to anyone that they know that might be going through a difficult time. So, and just support each other. That's all we can do.
Great. Well, thank you guys so much. This was a fantastic panel, and I think really rounded out even how we started out this morning. So thanks a ton.